Good morning, everybody. We're going to go ahead and get started. Happy Tuesday morning. Welcome to Grand Rounds. It's my pleasure to introduce our speaker, Dr. Brad Pasternak, this morning. Dr. Pasternak is a native of New Jersey. He went to medical school in Tel Aviv, Israel, at the Sackler School of Medicine, New York State American program. He did his pediatric residency in New York at the Downstate Medical Center in Brooklyn, New York, and then he did his fellowship in pediatric gastroenterology at Cincinnati Children's Hospital. He's been here at PCH since 2008. He's really developed an expertise in inflammatory bowel disease. He is currently the director of our Pediatric Inflammatory Bowel Disease Center here at Phoenix Children's, and he's on a number of national committees through various national organizations. And last year, I believe, he was named the Crohns and Colitis Foundation Southwest Chapter Physician of the Year. So please welcome Dr. Pasternak.
So thanks for having me. As Dr. Olson mentioned, so we just established our IBD program. We follow about 350 kids with inflammatory bowel disease here, and we've set up a multidisciplinary program here with psychology, surgery, nutrition, and so it's been great, and we've definitely seen improvement in our remission rates, and so it's been really good as far as setting that up. So I'm going to talk about pediatric IBD today, and just kind of where we are, and go through basics about diagnosis, evaluation, treatment, and obviously stop me if you have questions, and we'll go ahead. So this is a slide deck through our national organization, and it was through a grant. And these are some of my disclosures. So I speak for Ibd as well as Ibd Nutrition. So just to start, we'll begin talking about epidemiology. I think this is a classic case of kids are not little adults. Pediatric IBD presents very differently than adult IBD. And as far as treatment, again, the medications and things that we use are also tolerated differently by pediatric patients than adults. And we have to look at the long-term natural history of the condition. And I think we're seeing these kids present younger and more frequently in the pediatric age group than 10, 15 years ago. So this is the global prevalence of IBD. And interestingly, if you look at the map, high prevalence in westernized countries, and then you look at Africa, South America, really not a high prevalence at all. And a lot of people have theories about this and why this is the distribution of the disease. Something that is interesting is this whole hygiene hypothesis, which I don't know if you're familiar with that, but basically we're a much cleaner environment now, and you look at the countries that are affected by IBD, and these are again, the westernized countries, the ones that have good medication, good sanitary practices, et cetera. And so it's almost like, these countries that are cleaner, that are, that have good medical care, antibiotics, vaccinations, et cetera. These are the countries that have higher prevalence. And the thought is that our immune systems are developed differently in these countries than in Africa, where most of the country is exposed to parasitic infections, et cetera. So there's some interesting studies that look at all of that. But again, interesting slide. As far as the age of onset, again, I think this is shifting to the left, but typically teenage years, early 20s was always the peak of presentation of IBD. When I first joined the group, if we had a patient less than 6 that presented, it was exciting, sad, but exciting, where it was an interesting case, where now it doesn't surprise us to get patients that are 3 years old, 2 years old that present with Crohn's disease. And so definitely becoming more becoming earlier and incidence is increasing. There's a whole subset of patients that are called VEO IBD, very early onset IBD, which are patients who are less than 6 years old, and over the past 5 to 10 years, there's been a 100% increase in that population as far as incidence. So,
How much of that increase may seem apparent because of better diagnostic procedure techniques?
yeah, I mean, I definitely think that plays a role, but regardless, I think that there's a true increase in the disease itself. I'll show you a slide that kind of looks at that. So 25% of IBD occurs in childhood. Estimated 1.4 million people in the U.S. have IBD. 5,000 kids each year get diagnosed. So, it's quite prevalent. And here's that slide I was alluding to. If you look at a lot of these immune-related disorders, over the past 50 years, there's been a significant increase, and Crohn's being the most as far as incidence over the past 50 years, increase in incidence. So definitely something that we're recognizing much more. Clearly, some environmental factor is resulting in this. We just haven't identified what that is. With newer studies that are looking at the microbiome and all these really interesting findings, that's something that is definitely coming to the forefront of research, trying to determine changes in the microbiome, how diet affects it, how various medications affect the microbiome, and how that could influence disease. So natural history of IBD, as I mentioned, it is not the same as adult. In pediatrics, it's typically the colon that's involved. It's more diffuse. The progression is quicker than the adult or later onset IBD, where it's more just the ileum, less extensive. In ulcerative colitis, the kids typically present with pancolitis. And again, there's a shorter time until surgery in these kids. In the adult age group, more left-sided, it's localized. So again, different, and children do worse. It's a more severe disease in kids than in adults. So what is the pathogenesis, immunology? What are we thinking as far as pathophysiology? So the thought, this is a multifactorial condition. We know that there's some genetic susceptibility, and because of this, there's an environmental trigger in these genetically susceptible individuals that leads to this exaggerated mucosal immune response. And the thought is that it's related to the gut flora, that we live with trillions of bacteria in our gut, more bacteria in our gut than there are cells in our body. So we've got to learn how to live harmoniously with this bacteria. Patients with inflammatory bowel disease, their mucosal immune system reacts to the normal gut flora and creates this chronic inflammatory response. So in a normal host, you've got tolerance, controlled inflammation. They know how to live with this gut flora. Where there's an environmental trigger, you get some acute injury. Patients who have a genetic susceptibility, they lose tolerance and they react to the luminal bacteria and inflammation ensues. Where in a normal host, there's tolerance, they know how to handle it, and they get repair. So, this is the thought as far as pathophysiology in inflammatory bowel disease. And we mentioned there is a genetic component to this. Obviously, it's not a direct genetic relationship. It's a complex, multifactorial condition. It's polygenic. There's been a lot of genome-wide, there's been genome-wide association studies that have identified a lot of susceptibility genes. There's the relative risk for a sibling of an infected individual for Crohn's is about 30, for UC is 10. So again, we know there's this genetic association. Affected relatives, about 15 to 20%. So again, and one of the most important questions that we ask is family history of inflammatory bowel disease. That's definitely a high risk factor for a patient. The first gene that was recognized in IBD was something called the NOD2 gene, and that was when I was doing my fellowship. That's when that gene got identified. And it's interesting, the majority of the genes that have been identified to be associated with IBD all play a role in the mucosal immune system. They all play a role in how our body identifies bacteria and remains tolerant to them. And patients who have these genetic mutations in these various genes, their mucosal immune system is affected, and then they react abnormally to normal flora. So there's been an onslaught of genetic studies that have looked at Crohn's and colitis, and there's about 200 genes now that have been identified since that first one in about 2007. So again, it's a complex condition. It's not just one genetic abnormality. It's multiple genetic abnormalities. And so, a lot of our thoughts is that it's not even ulcerative colitis, indeterminate colitis, and Crohn's, but just a continuum of, patients that could present anywhere along that pathway. It's, where I trained in Cincinnati, there was a lot of discussion about personalized medicine and really trying to understand individual patients and if they're going to respond to certain medications versus others. This is a great condition to study that in because we're learning more and more about patients that have certain phenotypes, that have certain serologies, that have certain genetic abnormalities, etc. And learning which one of these patients would respond to certain medications may minimize some of the side effects in using medications that may not be effective. So how do we diagnose patients with IBD? So typically, the way a patient presents can give us a clue as far as what we're dealing with. Patients who have bloody diarrhea, running to the bathroom 20 to 30 times a day, they're going to have colonic disease. Patients who have growth failure, diarrhea, fatigue, most likely small bowel disease, Crohn's. So this is just a chart looking at signs and symptoms. Again, rectal bleeding, more common in ulcerative colitis, but you could still have Crohn's colitis, abdominal pain in both. And then when you're looking at some of the other factors, perianal disease is going to be Crohn's. You don't see that in ulcerative colitis. Growth failure, more likely Crohn's disease than ulcerative colitis. Weight loss, more likely Crohn's. So this is just kind of a breakdown of the two conditions. Now, how do we make the diagnosis? So obviously we suspect it. We get a good history exam. Like I mentioned, you need to know their family history. There's some labs that are helpful in terms of determining if they have active inflammation. Looking at a CRP, ESR, helpful. This is a protein-losing enteropathy, so a lot of them have low albumin. And that's also important when it comes to treating these patients because some of these medications, if they have low albumin, they need higher doses. There's another study that you guys have probably seen, the Calprotectin. That's a newer study. That's a stool test that's more sensitive than an ESR and a CRP as far as diagnosing inflammation in the gut. So we use a lot of Calprotectin. Correlates really well with the scope and imaging. Need to rule out the other etiologies, C. diff. Being important, there's a higher incidence of C. diff in patients with inflammatory bowel disease. If you suspect it, then you need to treat both. And then, again, you need to, I always say it's important to identify Crohn's versus colitis versus ulcerative colitis. As far as treatment goes, some are better in one condition than the other, but more importantly, when it comes to surgery, that's where it becomes important to differentiate. But at the onset, when you're treating the condition, many of the medications are effective for both, so it's not as important a diagnosis to make that distinction, and you still have time to really differentiate, but if a patient's going to go off to surgery, then it's important to know the difference. And to make that differentiation, so the main difference, Crohn's disease can affect anywhere in the GI tract, from mouth to anus, and So if there's any small bowel involvement, then it's going to be Crohn's disease for the most part. So we need to be able to look at the small bowel. And with a scope, we can only get so far from above and so far from below. And there's the whole middle area that is important if a patient comes with pancolitis and we don't know if they have Crohn's or ulcerative colitis. We need to see that middle area. So in the past, we did the upper GI small bowel follow-through, but there are better modalities now. So now we use an MRE, which is an MRI enterography. It's a more sensitive test to look at the small bowel with MRI. The problem is these kids have to drink a lot of contrast, and a lot of them don't feel well. They don't have appetites, and I could tell you when I ask kids, when I talk to them about further evaluation and we discuss either doing a scope or an MRE, I think 9 times out of 10 they choose a scope. I mean, they would rather do a cleanup than drink all that contrast, which always surprises me. But the MRE is something we utilize often. And then there's also something called a capsule endoscopy, which is a camera pill that transmits wirelessly. The problem with the capsule is that some patients with Crohn's disease could have a stricture, an obstruction, a blockage. So if they swallow this camera pill, it has the potential of getting stuck, and then they would need it to be surgically removed. Where I trained, they used to say, well, if it gets stuck, then they needed surgery in the first place, but I never felt comfortable using that as a diagnostic tool for a stricture. So that's the way we look at the small bowel, is MRE or capsule endoscopy. There's also extraintestinal manifestations that we need to identify. This is a systemic condition, so you can get abnormalities in the liver, primary sclerosing cholangitis. Joints are commonly affected. We get a lot of patients that come from rheumatology that have joint pain, growth failure. They see rheumatology, workup is negative, and then they come see us. Skin, so erythema nodosum, pyoderma gangrenosum, uveitis they can get. We typically like these kids to get annual eye exams. So yeah, we mentioned the labs. Again, CBC, sed rate, CRP, liver enzyme, serum albumin. These are just markers that help us identify inflammation and severity of disease. Not sure why I consider celiac serology, but patients can present similarly, so that's something we look at. And then looking at ruling out certain infections that can mimic IBD is important. Any patient that is flaring, the first thing we do is send stool studies to rule out an infectious etiology. So those are things that we need to look at. Now, one thing that's important also is this serology test. So this is another way that helps differentiate Crohn's disease from ulcerative colitis. So what these tests do, they look at certain antibodies to various microorganisms that there's 7 different antibodies that we look at now. And based on the pattern, we'll get a report back saying, pattern consistent with Crohn's disease or pattern consistent with ulcerative colitis. Now, I think for pediatricians, the important thing here is that this is not a diagnostic test. So if you're suspecting IBD in a patient, that doesn't mean we order this test, because we'll get patients sent to us for a clinic visit with an abnormal serology, and they clearly have bad irritable bowel syndrome, but somebody sent off this test that came back pattern consistent with Crohn's, and then we're stuck having to do a scope to show that it's not Crohn's disease. So this is not a diagnostic test. This is a test that we use once we made the diagnosis to help differentiate between ulcerative colitis and Crohn's. So again, if you look at the 4th, it's low sensitivity, unreliable as a screening tool. So it's helpful in a patient who's already been diagnosed. And we're learning more about these serologies and how we can utilize them. There was a study that looked at number of positive antibodies, and that was found to correlate with more severe disease, earlier surgery. So there's definitely use for them, but this is something that typically the GI doctor should order, and not just a patient who has diarrhea presenting to a pediatrician's office, because then it can confuse the picture. So again, as far as differentiating between the two, Crohn's could be anywhere. It's not continuous, so you're going to get skip lesions. Granulomas are pathognomonic, so we get biopsies back and there's a granuloma, it's Crohn's. But granulomas are only in about 40% of patients with Crohn's, so not having granulomas doesn't mean much, but it's always helpful if we see them. Transmural inflammation, that's always, that's always interesting when I ask residents about how do we differentiate it based on biopsy, and they say transmural inflammation, that's usually a problem because that means we perforated the kid. So we don't want transmural inflammation on biopsy, but if there's a surgically resected specimen, we have the pathologist really look at the specimen and tell us what's the depth of inflammation. Fistula, abscesses, strictures, that's all Crohn's disease. And that happens because of that transmural inflammation. So a fistula is basically an abnormal connection between the gut, and it could be anywhere. I mean, we've seen, a lot of times it just goes to the skin, but the fistulas ultimately lead to the abscesses. You can have rectovaginal fistulas. You could have, they can be anywhere. So those are important to identify. The ileum being involved in Crohn's. Now, it's a little bit tricky because some patients have pancolitis. Their whole colon is involved. And when we get the pathology back, it'll say acute ileitis. And what we've learned is that if you have your entire colon involved with pancolitis and you have some ileitis, that doesn't necessarily mean Crohn's disease in that particular situation. So ileitis with pancolitis could still be ulcerative colitis. It's just the inflammation backwashed into the ileum, so it's a little bit tricky as far as that scenario. With ulcerative colitis, again, there's no granulomas, the rectum's involved. It's just the mucosal inflammation. It's not transmural, and they don't get abscesses, strictures. There's no perianal disease, so more superficial. And again, this is just the upper GI small bowel looking at here the ileum. That's not showing up. But you see the terminal ileum there is narrow, probably a stricture there, inflammation. So when you're looking at the scope, on the left is what a normal ileum looks like. You can see all those bumps are the Peyer's patches, so you get all that, the lymphatics, and on the right you can see the ulcerations there, the exudate. So that's what we see when we're doing our scope. And then when we look at the colon itself on the left, it's normal, smooth. You can see the blood vessels. Don't see any ulcers. In the middle, ulcerative colitis. It's granular. You lose the blood vessels. You can't see any of that. And then on the right, it's more cobblestone. You see those bumps, fissuring, etc. So that's more Crohn's disease. So that's what it looks like endoscopically. And as I mentioned, when we're looking at extraintestinal manifestations, again, the joints are commonly involved. And usually active disease is when we see a lot of these extraintestinal manifestations. The skin, the eyes. A lot of these kids get oral ulcers, and then hepatobiliary, primary sclerosing cholangitis, more common in ulcerative colitis, and autoimmune hepatitis we have to look for. So a lot of other systems involved. And here's just some examples. So eye involvement, then the erythema nodosum, so the painful lesions on the shin. Again, you got to treat the disease, and that usually treats the underlying issue. And I think one of the most important things that differentiate pediatrics from adult is is the growth issues and growth failure. So for us, their growth curve, looking at their growth, that's another vital sign for IBD, where in the adult population, they don't worry about this, they don't look at this, they use a lot of steroids, and this isn't something that concerns them. So typically, Crohn's disease is where growth is affected. Up to 85% of patients with Crohn's have affected growth, and it's as far as treatment goes, it's really a race against puberty. I mean, we want to get their disease under control before they reach their growth spurt, because active disease is going to affect their final adult potential. So overall, pediatric IBD, 35% have affected growth, but as I mentioned, the majority is in Crohn's disease. And here's just an example. So, this is a patient with Crohn's, and you just look at his growth failure. And often they'll have decreased height velocity before they have any GI symptoms at all. I think Dr. Olson could attest to patients showing up to endocrine with growth failure, and growth hormone testing's all normal, and they'll have an elevated SED rate, and then they're sent to us. We scope, and they've got active inflammation, but they've never had any GI symptoms, and they've got Crohn's disease. So 25% of patients may not achieve their full height, and we know that some of it is our fault. Steroids are terrible, and we used to use a lot more steroids, and a lot of the newer drugs that came out came out because we want steroid-sparing therapy. So some of the growth failure is secondary to iatrogenic issues, and like I mentioned, we want to intervene before they complete puberty. So as far as etiology of growth failure, we've got a condition where kids they don't absorb nutrients. They're not hungry, so they have decreased calorie intake. They have chronic diarrhea, so they're losing their nutrients. They have chronic inflammation, so they need more calories. So, this is just a whole setup for poor growth. Then on top of that, the inflammation alone, the cytokines affect growth, and then we throw them on steroids. So really, it's everything is set up for poor growth in this condition. So that is our goal. And one of the barometers that we look at is patients at risk nutritionally and how they're doing from a growth standpoint. So again, we need to be aggressive in these kids and really get them under control early when they're more inflamed, when they're not having strictures. So what do we do? How do we manage these patients, and what are our goals? So obviously, we want to maximize their therapeutic response, minimize any side effects. So again, we want to minimize any steroid use. When you look at quality of life studies, it's interesting, and Crohn's disease actually comes out as one of the top conditions that affect quality of life, which is completely understandable. We want to promote psychological growth, physical growth, pubertal development, and we want to prevent any disease complications. So, and we'll talk more about a lot of this, but things have definitely changed over the past 10 years as far as the landscape of medications. But when you're looking at mild disease, the aminosalicylates, so those are the 5-ASA drugs, the sulfa drugs, Colazol, Asacol, Pentasa. We'll talk more about it, but for Crohn's disease, we use them here and there. They're not as great as some of the other medications. Antibiotics are interesting because when you think of the pathophysiology of the condition, and you're talking about the gut flora, microbiome, bacteria, you would think that maybe antibiotics would play a bigger role. But again, we'll talk more about it in a little bit, but the studies have not really panned out that way. Enteral feeds is I think, one of the most interesting topics that we're dealing with now. When I trained, people talked about diet, and I mean, the first question parents would ask is, well, what can my kid eat? You know, and how do I change the diet to help this? And it was always, well, when your child's in remission, you really don't have to worry, and you can just eat whatever you want, and when you're flaring, just try to minimize stool output. But things have definitely changed, and in Europe, enteral nutrition is it's a therapy, and we'll go into some of the data, but in Europe, that's first-line therapy. They don't consider drugs in anyone until they try enteral nutrition as therapy, and we'll talk more about that. Steroids, we talked about that. There are other steroids that have come out, budesonide, so that's Entocort, Euceris. These are steroids that avoid that first pass metabolism, so you don't get all those systemic side effects, and so we really try to minimize prednisone and utilize more of the budesonide. For moderate to severe Crohn's, again, enteral feeds, we'll talk more about that. Steroids, like we said. And then there's these immunomodulators, so 6-MP, azathioprine, methotrexate, and biologics. There's more to that list now than these three. And if you look, they talk about induction and maintenance. So I always tell families, we want to get them feeling better quickly. And then we need to maintain the disease. This is a chronic condition. Their child's going to be on medication until the unforeseeable future. I mean, so diagnosing a 3-year-old with Crohn's disease is tough because, again, I can't tell that there's no exit strategy. I can't tell them when they're ever going to get off a drug, and I hope in the future there'll be a cure, but for as long as they're with me or us, they're going to be on medication. Now, again, induction, we want them getting better quickly. So the medications up there that say induction, they work fast. Maintenance is, again, is to try to minimize any relapses, any flares, but also minimize steroids. And the reason why immunomodulators are just written as maintenance, they take about 3 to 4 months to really work. So when you diagnose a patient, you're not going to just put them on 6-MP and wait 3 months for them to respond to it. So a lot of times we'll start 2 drugs at the same time, or just choose one that will serve the purpose of both induction and maintenance. Now these are pictures of the aminosalicylates, and like I said, they're sort of falling out of favor because we have a lot better drugs that are out now, but they work in different areas of the GI tract, and that's how we decide which one we're going to use. A big issue with the aminosalicylates is the pill burden, and one of the biggest problems in kids is adherence, and some of these drugs, so valsalazide, you know, on the right, that's Colazole, that's 3 pills 3 times a day. So you're going from taking no medication to potentially steroids plus valsalazide and maybe a PPI. So you go from 0 to 12 pills. And that's not easy. You can open that capsule, so for younger kids, they don't have to swallow the pill. But here's, you know, this is just looking at maintenance for Crohn's disease and a bunch of studies looking at a meta-analysis, and you know, it favors the treatment group slightly. It's not drastic, but there is some role for this, and so definitely much better in ulcerative colitis, and I'll show you that data too. We talked about antibiotic therapy. Again, the rationale is to treat the bacteria, but the data was not that strong. They looked at Flagyl, they looked at Cipro. It's good for perianal disease, but other than that, not a great strategy. Same with probiotics have really no role in treating IBD except for one particular scenario, which is a patient who had a colectomy and has a pouch. There's some evidence that using probiotics is helpful to prevent inflammation of the pouch, but other than that, not beneficial. So nutritional therapy, so like I was mentioning, this has become really interesting. And like I said, first-line therapy in Europe, and there are definitely certain institutions here that promote it a lot more than others. I don't know, we probably have a dozen kids doing enteral therapy. And so what does that mean? Basically, if we take their caloric needs, there's a couple different scenarios. There are some places that do 100% of their caloric needs. They drink formula, and that's their treatment. And it could be any formula. It doesn't have to be Elecare or something broken down. So it could be Pediasure 1.5. I mean, I usually use the 1.5s because then they don't have to drink as much. But what we do is an 80-20. So 80% of their caloric needs, they drink formula, 20% more liberalized. And studies show that about 85% remission rates. I know at CHOP, they utilize it quite a bit. They have the highest percentage, and in their data is about 85% remission. So definitely more effective for small bowel disease. Colonic disease, not great. So if you have a patient with ulcerative colitis, doesn't work that well. This is interesting studies looking at enteral nutrition versus prednisone as far as inducing remission, and they're equal. So nutrition is just as good as prednisone when it comes to treating the inflammation. I mean, they didn't look at a combination, but my thoughts are, why choose steroids and all those side effects if nutrition's equally effective? Obviously, you're not going to get growth issues if you're giving nutrition. There's no side effects. The issue is trying to get the kids to buy into 80% of their diet being formula. And correct. So typically the induction period is about 3 months, and it's every day. They do 80-20, and then after 3 months, for maintenance, we take a day out. So they'll do 6 days out of the week for a month, and then ultimately 5 days out of the week. So they get 2 days off. That's their maintenance. But it's therapy. They need to be motivated. There are some places where they have kids drop NG tubes at night and just do a night trip of 80% of their nutrition, and during the day they're more liberalized. We've talked about, it's tough. I mean, these kids they try it, they'll do it for a little bit, then they get sick and tired of it. They want to eat what their friends are eating. They don't want to drop an NG tube. So yeah, it's just not that easy to convince them to do it. But once the kids that do and are motivated do pretty well on it. There's some other diets as well that are being studied. There's something called the specific carbohydrate diet. This is something that is being studied now as far as treatment, and it's basically removing most carbohydrates from the diet and seeing if it's effective. And there's been some benefit. So we'll see how nutrition plays out overall as therapy. Steroids we talked about. Again, rarely used as monotherapy because you can't keep kids on it, and you need to maintain their disease. And you can't maintain them, like I said. And as far as response to steroids, I always say it's about a third. So 1/3 will respond right away. You wean them off, and they're doing fine. A third, as you wean them, they relapse, and you need to go back up on steroids because they flared. And then a third don't respond at all and end up going to surgery. So again, not a great therapy. And then we know, obviously, it impairs growth. So daily prednisone is the yellow bar versus no prednisone, and significant impact on growth in these kids. And then on top of that, all the other side effects. So we can't just ignore the fact that, these kids, they get acne, moon face, gain weight. I mean, they're not good drugs for kids. And then, looking at immunomodulators and biologics, so this is really, biologics have really become the the forefront of therapy. Indications, again, induction and maintains disease, typically fistulizing disease, moderate to severe disease, patients who can't get off steroids. We use it in kids who have had surgery to prevent recurrence, etc. So, these are the immunomodulators now. So 6-MP, azathioprine, methotrexate. When I discuss this with the families, what I tell them is, yeah, there are side effects, but we have pretty good control over this medication. The side effects are dose dependent, so we monitor. We also check something called TPMT, which is an enzyme that breaks down the medication into its active metabolite. And there's a percentage of patients that don't have it. They're going to have bad side effects, so we won't use it. And we can check metabolite levels. So we have the ability to monitor adherence. Obviously, if a patient's flaring on this drug, we'll check levels. We'll see that their levels are 0, and then we know they're not taking it. And so yeah, we have total control over it. Methotrexate, we've been using, and data recently came out that it's effective, but again, I don't like using it in the teenage girls where there's some teratogenic effects later on, and so there's some issues here. It takes about 3 months to take effect, so these are not good drugs for induction. This was the study, kind of the pivotal study that showed its benefit. So on the top, these are patients who were maintained with 6-MP, and on the bottom, they just control patients, and it was almost a 90% remission rate in the patients that were maintained on 6-MP. Definitely not as strong in clinical practice as the data suggests, but this was the study that had us all putting everyone on the drug. Again, the issues are the side effects. I think the main side effects, I always say there's 2 routes. Either you're going to get liver toxicity or bone marrow suppression. And then there's this risk of lymphoma later on as well that families obviously are always concerned about. So again, risk of lymphoma, but again, maintaining remission seems to be greater than the lymphoma risk. So while it's important to discuss with the families, it's still a decent medication. And then, last, as far as medication goes, the biologics are probably the best medicine we have. If you look at side effect profile and then you look at benefit, these are the most effective medications. They work quickly, and side effect wise, again, while a lot of families get scared because it's either an infusion or a shot, they automatically assume it's a stronger, big gun. Side effect wise, definitely less than the thiopurines. And like I said, much more effective. Initially, anti-TNF was the only mechanism that was out. And TNF is a cytokine it's an inflammatory cytokine that is the highest cytokine in a lot of these patients. And so targeting it was very effective. The problem was this was our only agent, and patients could develop antibodies to the medication, or they could have a reaction. And if that happened, we were left really saying we don't have much else to offer, and it may, surgery was likely the next step. There are newer drugs that have been coming out. Every year there's a newer drug, a newer mechanism. So we have alternatives now where we're not stuck with just an anti-TNF. And just looking at some of the data, if you look at the REACH trial, that was the trial that got Remicade approved for pediatric Crohn's. Clinical response at 10 weeks, 88% in the pediatric population. So that's a really good response rate, about 60% remission at a year. Compared to the adults, the adult data is on the left, 67% response rate. So kids did a lot better than the adults when they looked at the studies. And that made people think, why are we getting much better data in pediatrics than the adults? And they started looking at some of the differences in the studies, and we were starting kids on these drugs 2 to 3 years after diagnosis. They were much more inflammatory, less stricturing, and the thought was, in the adult population, maybe they should be doing what we call top-down therapy, starting adults on the drug much earlier as opposed to waiting, and so kind of changed the landscape of how we've been treating the disease, and a lot more people are getting the biologics earlier on because they're more effective. So as far as adverse effects, most common is just typical standard URI infections. They all need to get their flu shot. Prior to starting a biologic, we always check TB status, we check hepatitis B status. They can't get live vaccines. So these are all the important things to discuss with families. But what came out, so if you look at the rare but important ones, the top one, so that's hepatosplenic T-cell lymphoma. So that got reported. There's been about 45 cases of this that have been reported. And this is specific lymphoma in IBD patients that have been exposed to biologics, but the issue, what we learned is that every patient who had gotten this particular lymphoma was also exposed to 6-MP or azathioprine. And there were no patients that were on a biologic alone, but there were patients who got 6-MP or azathioprine alone who developed it. So while families will Google the med and they'll see this, and it's fatal, there's no cure. So everyone who's gotten it has died, and they read that and they freak out. But you have to put it into perspective. And number one, I always say I think it's on the label's on the wrong drug. And then number two, the risk, you're talking 45 patients out of millions and millions of patients. So relative risk is quite small, but we used to do combination therapy. We used to put a lot of kids on both azathioprine 6-MP and a biologic because they work better together. They're synergistic. You get less antibody production, you get higher drug levels. But once this came out, and it affects adolescents more than adults, males more than females. So once this came out, we all stopped using combination therapy because we were scared of that side effect. And then we started seeing kids not do as well. So people are going back to using combination therapy, but again, we have to keep an eye on that particular side effect. And then for ulcerative colitis, like I said, it's a little bit different than Crohn's. Kids do better on the 5-ASA drugs, the aminosalicylates. So we use them for sure in ulcerative colitis. Mild to moderate for sure. Moderate to severe, again, same drugs. Talked about the delivery system. So again, they work really well in the colon. They don't work very well in the small bowel, the 5 aminosalicylates. And we also have topical therapy. So there are some patients where, I've got patients who have maybe 5 centimeters of disease. I'm not going to throw them on steroids and, a lot of these systemic drugs if I can actually just give them a suppository that'll treat the 5 centimeters. So if we could treat it topically, that's always the best because we could give maximal therapy and minimize side effects. So there's enemas, there's suppositories, so we utilize those as well. And if you look, again, much better in ulcerative colitis when you're looking at favoring treatment with a 5-ASA. And again, for maintenance as well. Steroids, same sort of story with ulcerative colitis. A third are going to do well, a third are going to become dependent, and a third typically go off to surgery at some point. And then when you're looking at the immunomodulators, same story. We're trying to minimize steroid exposure. They don't work as well in ulcerative colitis as they do in Crohn's, but there are some patients that respond. As far as biologics, I don't think it's being defined anymore. I think it's been defined. It's definitely a good medication. I don't know if any of you guys have been on the floor recently, but we've had an onslaught of patients coming in with acute severe colitis. I think there were like 7 kids hospitalized last week or last month with bad disease. You know, that's an interesting discussion, because we get patients, they'll present with acute severe colitis, show up, get admitted, and the first step is IV steroids. I mean, we really want to get this under control. But we just created a pathway. I think I sent you that the pathway recently, to try to really get these kids managed, because we've had so many patients come in, and we wanted to standardize how we treat this. But now that we've got the biologics, it used to be steroids, and if you don't respond, you get your colon out. And that's not the case anymore. And now it's steroids. If you don't respond, we'll typically try a biologic, and a lot of kids do well. And we save their colon, and they end up being maintained on the biologic and never have a problem. So we definitely see significant changes in the natural history with these newer drugs. But when it comes to surgery, again, I mean, that's an option. Ulcerative colitis, people say, oh, well, if I have surgery, it's a cure. But that's not really how it's not a cure. It's you know, you're trading it in for other potential issues. These kids get, typically, it's a 2-step procedure, sometimes 3 steps. They get an ostomy, you know, they get a bag for a little while, let things calm down. Then they'll get something called a J pouch, where the surgeon will bring down the small bowel, create a rectum out of the small bowel, and that area always has potential to become inflamed. There's something called pouchitis, which, you know, sometimes is just as bad as the disease itself. They usually leave a little bit of rectum, which could also get inflamed. So we have to continuously monitor these patients after surgery. They typically have 6 to 7 bowel movements a day after surgery, so it's not like they're going normally. It's always going to be loose. So it's again, it's not necessarily a cure. With Crohn's disease, about 75% of patients with Crohn's will ultimately require surgery, and once you get one surgery, it increases your risk for another surgery. Indications for surgery in Crohn's: failing medical therapy, if they have an obstruction, perforation, abscess. Growth retardation, I wouldn't say is necessarily an indication for surgery, unless they have an area that you just can't get under control. And then in ulcerative colitis, again, they have a bad hemorrhage, you can't get the disease under control, if they're transfusion dependent, medically refractory, etc. So, you know, about 30% of patients will have a colectomy at some point within the first 10 years of their disease. So a lot of them do end up requiring surgery. So that's a lot of information. I don't know if you have any questions or.
On the late adolescent, the 20-year-olds with Crohn's disease are diagnosed at that age, has there been any data to show about their heights and weights as adults?
Yeah, I mean, if they're diagnosed later, after they've gone through puberty and all of that, then they don't.
They haven't had any symptoms up to that point. Is there a group of patients that you find
Smaller because of maybe having underlying Crohn's earlier that wasn't diagnosed? Is that? Not typically the older, when kids are, or when patients are diagnosed later on, they don't suffer the growth issues. It's more the earlier teenage patients or younger that have the growth issues. But that's a good question. I don't know if it's been looked at as far as are they shorter just because maybe they had throat failure but never had any GI issues previously and went undiagnosed.
So, you brought up a good point about throat failure, and not having major other GI symptoms, and it might just seem one or two might have two. But, our tendency is to look for a CRP or something, and that's not going to be positive for not declare.
Yeah.
What can we look for? What can we do to
Yeah,
evaluate for this?
there's not much. I mean, it'd be interesting to know if a calprotectin would be effective in that population, because that's a more sensitive test for inflammation. If your workup is totally negative, then I still think send to us, and whether we do an MRE or just scope, that would be the way to look at it. 'Cause mild disease, 40% of patients with mild disease, their labs are normal. So having normal labs does not mean they don't have Crohn's, and that's the tricky part, especially if you have a kid with just throat failure, no active other symptoms. There's that potential that they'll have normal labs.
Or just a little low, seems like a lot of these cases they would catch like that.
Yeah, so,
Not crazy low, but it's just a little bit low.
but I would say throat failure with no other, which is a reason to either image or scope.
Just a little more, your thoughts about biologics of ulcerative colitis and also the potential cancer risk of losing it plus cold and longer and height.
Yeah, I mean, I think ultimately the cancer risk is not that high. I mean, I always tell families, if you drove to clinic today or you drove to your infusion today, you put your kid at higher risk of death. Because, getting into a fatal car accident, the risk is higher than getting that particular cancer. So I don't think that's a big deal. If I ask family, when you talk to family, we always give them that option. And we're like, okay, you are not responding to steroids. We need to come up with a plan here. And there's two directions. We could go to surgery, or we could try one more medication to see if it works. It may not work, and I would say, maybe 1% would say, I just want my colon out, and 99% say, I want to try something else. So, and the other question is that if they're that bad at the onset, what is the likelihood that they're going to maintain their disease? And these are things that we're looking at, because we've had the biologics for 10, 15 years, and now we can kind of see what the natural history is. Are we really changing the disease process with these drugs?